Hello everyone, thank you for giving me your time today. My name is Tanner Rozendal and my project is titled Treating Systems and Symptoms, an elective medical school rotation to improve public health, medical curriculum, and carceral healthcare. Now before we begin, I'd like to establish some language and limitations necessary to this conversation. Firstly, the carceral system refers to the network of institutions, such as prisons and facilities, where incarcerated individuals may be held. Persons in custody, incarcerated individuals, and inmates are used interchangeably throughout this presentation. Additionally, there are a host of ethical debates surrounding prisons. However, these are beyond the scope of this analysis. And finally, many persons in custody have committed acts that pose a danger to themselves or others. This does not discount the complex systems that contribute to incarceration. Now, most of the data from this presentation is from the Prison Policy Initiative, a nonprofit and nonpartisan research organization focusing on the carceral system. So, who is incarcerated and why should you care? My first point is that we live in a period of mass incarceration. 1 in 5 people in the world are incarcerated in the US, as seen on the top. And the US has a 4 times higher incarceration rate compared to similar NATO countries, as seen below. Additionally, there are more than 2 million individuals incarcerated in the US, with the largest population in state facilities. In Oregon, nearly 2% of all residents are under some sort of surveillance, including probation, parole, and confinement, as seen in the red box. Secondly, carceral healthcare is inadequate. In the top figure, we see half of those entering carceral facilities self-report a substance use disorder, yet only 1 in 10 of those declaring a substance use disorder receive treatment. This is self-reported, and in reality, those who have a substance use disorder are likely much higher. In the bottom figure, we see half of those entering carceral facilities self-report a mental health problem, yet only 1 in 14 currently receive treatment. The inadequacy of the carceral system is especially true for mothers, where 1 in 5 states fail to provide breast pumps or a postpartum diet. The worst offenders are highlighted in teal. Finally, there are racial and ethnic disparities in correctional facilities. The overrepresentation of these groups exacerbate pre-existing health inequity that results in poor health outcomes. The third, and perhaps most relevant discussion for today, is that carceral system directly affects public health. The first thing to note is that while you may not be incarcerated, there's a high likelihood that you know someone who has been incarcerated. There are over 113 million adults, 1 in 3 people in the US, who have an immediate family member who has been to prison or jail. 1 in 3 people. On average, these people lose 2.6 years of life expectancy in relation to a single family member incarcerated. This number is only greater if you have multiple family members. Next, I will draw your attention to this statistic. Formerly incarcerated populations are 10 times more likely to be homeless compared to the general public. The homeless and unhoused populations are gaining attention in the legislature, and likely has affected you in some way. Secondly, 80% of inmates leave prison with a chronic health condition. These chronic health conditions are expensive to manage and care for, with 3 primary effects. First, they increase the burden on hospitals, especially emergency departments. They also increase disease transmission in the community, and the economic burden falls back onto the community. Now, these adverse outcomes are exacerbated by these high rates of chronic disease. Indeed, the US spent an estimated $1 trillion on healthcare managing chronic diseases alone in 2017, and that number is only expected to increase. Now I'll draw your attention to the top right corner, where a bill was passed to allow access to Medicare for people within 138% of the federal poverty line. In states that agreed to this expansion, a 20% reduction in all arrests were observed in the first 3 years following this bill. In other words, healthcare access is correlated to dramatic reductions in crime. This is a huge deal, suggesting that proactive access to healthcare is a key component to reducing crime and improving public health. Now, my last point for why you should care about this population is that there are economic losses for all parties involved. For those incarcerated, the aggregate annual earnings, so money that the US economy is missing out on, totals to roughly $400 billion. Additionally, for people who have been imprisoned, they lose up to $500,000 in earnings over the course of their career. The carceral system, thus, perpetuates cycles of poverty and trauma, resulting in an economic burden. Now, in terms of the cost of the system, housing per inmate is about $6,000 per year on average, but it goes up to $16,000, and this is data as of 2015. Altogether, the U.S. spends a total of $182 billion on the carceral system and about $81 billion on public prisons. This is, by estimate, 3 times the discretionary spending on scientific innovation and about 1.5 times the discretionary spending on education. Evidently, the carceral system is extremely expensive. Now let's discuss the current infrastructure of healthcare inside prisons. Most prisoners are subjected to an entry examination, and then some inpatient facilities are provided by nurses and general practitioners, seen here. However, most medical care, especially outside of general services, is done in outpatient facilities. For these outpatient procedures, inmates are shackled with a police escort, both a costly and humiliating effort. The 2 stars on your screen are where my proposal intends to intervene, both in the entry examination and in the care inside of a prison. So the bottom line is that the carceral system is broken. It fails to provide adequate health care, undermines public health, and perpetuates cycles of trauma and poverty across generations. I'd like you to take a moment to investigate this broken pyramid. The $81 billion in annual expenses results in 70% recidivism within 5 years, 80% leave with a chronic disease, 10 times more likely to be homeless, and 27% unemployed after 1 year. Now, take a step back. What was the initial interest in prison? Through the prison education program, I took an Inside Out class last year. Each Monday for 10 weeks, 12 UO students would take a class with 12 incarcerated individuals for 3 hours. The course, titled Political Agency as Autobiography, was taught by Professor Anita Chari, seen in the top, a political theorist who uses somatic-based teaching practices in her classes. Pictured bottom right is Dr. Shulul Cohen, the director of the prison education program. This course changed not only my outlook and understanding of the world, but also my future plans. The project that I propose for you all today is the culmination of 10 weeks inside a prison that catalyzed reflection and personal growth. I encourage all students to attend and take classes if given the chance. Now, I'd like you to consider this quote. In prison, relationships are contraband. Think about what relationships you have in your life. Relationships with your friends, your family, your neighbors, even your partner. Think about the number of people you talk to today. What do these relationships mean to you? What function do they have in your lives? Relationships provide emotional support, they assist with identity formation, they build community. Relationships are linked with healthier and longer lives, lower stress levels, and they support physical and mental health. Now imagine that your relationships are illegal. There are forces of power that work actively to remove and break these relationships. How does this make you feel? This is what incarceration is like. In prison, relationships are contraband. Indeed, the effect of this culture is to lock away the numerous physical, mental, and emotional benefits provided by our relationships. Now, I had 2 main takeaways from my experience taking a class inside a prison for which I'd like to share with you. The first is that denying an individual relationships is denying the individual the opportunity to reform. Secondly, relationships are banned in prisons because they are powerful. They catalyze change and healing. These 2 points changed my perspective and interpretation of relationships. In my former years, I viewed relationships as transactional. They were rooted in expectation. Then, after the prison course, my perspective changed to appreciate the power of relationships when rooted in connection. This is especially true as a pre-med student, where only 1 in 20 applicants get into medical school. It's difficult to avoid the competition with one another when facing these challenges. Therefore, the inspiration for this project was in part to share these lessons with my medical colleagues. This brings us to the proposal. The program I designed is a 6-week elective medical school rotation inside of carceral facilities. It includes 3 parts. So during the first 2 weeks, there are intensive didactic seminars with curriculum focused on somatic-based and trauma-informed care. These are pictured here. Trauma-informed care is important to teach students to identify common trauma responses in patients, adapt communications to build trust, and create environments that support psychological safety. Somatic-based care is important to teach students to recognize how stress and trauma manifest in the body and apply simple techniques, such as grounding and breathwork, to support patients in the program. The last 4 weeks of this program, pictured here, includes supervised patient care for inmates less than 90 days from release. This 90-day window is important because research suggests that the care for 90 days prior to release is optimal for managing substance use disorders and addiction. Additionally, legislation set to take effect on January 1st of 2026 prevents the termination of Medicaid for incarcerated populations. Now, the other important thing here is to work with transitional clinic networks, or TCNs, to continue the care post-release. I will go into these TCNs in the coming slides, but the collaboration with these networks is vital to the success of the program. Such collaboration ensures that the care received is consistent upon leaving the carceral setting. Now, the third part of the program is an inside-out model course that runs during the 6 weeks that includes medical students, undergraduates, and persons in custody that once again uses somatic-based teaching practices. The goal here is twofold, both developing relationships with the prison and secondly, facilitating a diverse group of students to experience the rehabilitative transformation that I was involved in. So pictured here is an example of when such a rotation would take place during the 4th year of medical school, which is pictured here, with the first 2 dedicated to lecture-based content, as is the norm. Now, there are benefits to public and community health. With improved management of chronic disease, the healthcare workforce is also better equipped and better trained to care for chronic health issues in resource-limited settings. This in turn will reduce healthcare costs and current burdens on the medical system. It also bolsters the economy and creates leaders in health equity policy. The benefits to medical students are numerous, including training a more educated population regarding chronic disease and addiction management, as well as supplementing medical school curriculum. For those incarcerated, there's increased access to screening, alleviated staffing shortages, and the opportunity to build relationships necessary for reform. Now, is there evidence that this will work? Indeed, there are numerous previous programs that are models for this success. Rhode Island Corrections did the first ever use of medical-assisted opioid treatment with great success. The emphasis here is on the continuity of care. Norway is considered the model of carceral systems, with only about a 20% recidivism rate. In Norway, healthcare and occupational training are a priority. The Inside Out Prison Education Program has built consistent relationships with institutions and carceral facilities. These relationships are important for the implementation of this program. Doctors Without Borders provides a model for providing healthcare in resource-limited settings. And then 2 important pieces of work that came from lawmakers. The first was to Congress emphasize the importance of principles included in my proposal, and the second, published by an Oregon committee, recommended direct involvement of medical students inside of carceral facilities. And I was very excited when I found these. And there are also numerous broader programs working for similar outcomes. These include Reentry 2030, the Veterans Justice Initiative, and then again, and perhaps the most promising, Transitions Clinic Networks, or TCNs. So the key here is leveraging existing systems and established partnerships will strengthen the feasibility and the impact of this program. Now, there's a question of funding. So how will this be funded? Transitional clinic networks, which I mentioned briefly before, provide models that offer insight. There are 48 TCNs across 21 states. These facilities train community health workers with online curriculum. They have 12 modules that are pictured here. And this curriculum can be adapted to the exact project that I'm proposing. Additionally, there's been great success with this program and research that has been done. So there was a 51% reduction in overall emergency room utilization for those involved, and every dollar invested in a TCN yielded $2.50 back to the state. So it's a huge opportunity for economical savings. Additionally, patients' preventable hospitalizations were cut in half, and formerly incarcerated individuals, when they were involved in healthcare post-release, increased the attendance at these appointments from 30 to 70%. So together these indicate that the design I propose, incorporating both healthcare professionals and those incarcerated, is effective to deliver care. Now, most importantly, this model is very cost-effective and saves the state money. Per healthcare worker hired, the state saves nearly $30,000 per year. Now, to get the program off the ground, there are numerous grants available through existing agencies such as Medicaid, SAMHSA, NCCHC, and HRSA. However, I believe the key to long-term retention is Medicaid funding, and with the bill set to prohibit termination of Medicaid benefits for those incarcerated, this is one avenue that we can lobby for and push to enact these changes. Indeed, Medicaid spending is expected to increase as the years go on. Now, this brings me to my implementation timeline. I am a junior now, and after graduation, I will contact candidate programs. Stanford and Yale are at the top of my list currently. In the 2026 to 27 year, I will both refine the proposal and submit grant applications. I'm currently working on a grant application right now. Then the following year, I will pilot the program and welcome the first cohort of students by the 2028-2029 school year. And finally, I myself will engage in the program in the 2030 school year. Finally, 3 materials came with this project and will be used moving forward. The first is a formalized letter of intent. Then there's a public health flyer to garner support. And finally, a detailed proposal such as the one presented today. So despite the flaws in our carceral system, the heart of this proposal is simple. It's when we start working together that the real healing takes place. So I leave you with this. If we want to treat systems and symptoms, we must start by nurturing the relationships that sustain us. Thank you for your time.